Hello, everybody, and a very, very warm welcome. Thank you so much for joining us today. I'm absolutely delighted to introduce our guest, Dr. Robert McGeachan. Rob is currently part of the prestigious clinical academic track at the University of Edinburgh, where he balances cutting-edge research with his clinical residency in veterinary, neurology, and neurosurgery. What makes Rob's work so amazingly special and so vital to what we do here at Humanimal Trust is his one medicine approach. Because by studying how neurodegenerative diseases like Alzheimer's affect both humans and animals, Rob is finding ways to advance treatments that benefit all species. His research has already made waves in major scientific journals and across international media. But beyond his credentials, he is a dedicated advocate for collaborative medicine. On a personal note, I just want to say a huge thank you, Rob, because you've been an incredible supporter of Humanimal Trust, and we are so grateful to have your expertise and passion here with us today. So, Rob, thank you for being here. We know how busy you are, but the floor is now yours.
Thank you very much. And thank you everyone for coming to listen to me ramble on about dementia for a little bit. So I'm just going to share my screen and make sure you can all see my slides. Thank you so much for the kind introduction, and hopefully I can live up to that. But we'll see. So I just want to double check that you can see my slides and hear me. Yeah, perfect. I can see you. Perfect. So this is a little bit of a whistle stop tour, and actually I might whiz through some bits to maybe leave more room for questions towards the end, but hopefully you find it interesting. So really my sort of passion and focus is on neurodegenerative disorders, and specifically dementia-causing disorders. So first of all, we need to sort of really clarify what dementia is. Now, dementia isn't a disease. Dementia is a set of clinical signs or clinical symptoms which are associated with cognitive impairment. Now, it's been renamed as major neurocognitive disorder in the sort of academic setting, although I still think dementia is just generally much widely used outside of this. Now, many diseases can cause the symptoms of dementia, but Alzheimer's disease is the most common cause of dementia. And then vascular dementia is our second most common cause. And then there's lots and lots of other neurodegenerative disorders that can cause dementia. Now, the diagnoses of dementia depends a little bit on what framework's being used, and it's evolved over the last couple of decades quite substantially. But it's quite important, and especially when we come back to when we're thinking about dementia in our pets, which I'll come on to later. But in humans, the NIA framework anyway defines dementia as significant cognitive decline evident across one or more of the domains that they have as either memory, executive function, language, visuospatial ability, or social cognition. And again, what's important to think about here is that this cognitive decline is not only done by a history and a clinical assessment, but there's also objective cognitive testing that's performed, and a lot of work has gone into these objective cognitive tests in people. Now, there needs to be some evidence that there's a functional impairment and that it's interfering with people's everyday lives. And often this is useful to talk to people's family, their children, their partners, to find out how these people are coping and actually living with dementia. And importantly, that these clinical symptoms cannot be explained by any other disease process that they have going on. For example, delirium, which can often be caused by things like urinary tract infections in older people. So why is dementia important? Why do we care about it? And why should we study it? Well, it has a high prevalence. There's approximately nearly 1 million people living with dementia in the UK and 55 million people living with dementia worldwide. And due to an aging population, this prevalence is expected to increase. And therefore, 1 in 3 people born today within the UK will develop dementia in their lifetime. So really quite staggering numbers. And the global prevalence of dementia is expected to triple by 2050. So currently we're about that 50 million people worldwide. And by 2050, without the advent of disease-modifying therapies for dementia-causing disorders, we're looking at approximately 140 million people worldwide living with dementia by 2050. So, not only is this a huge number of people affected by the disease, but also it has a huge socioeconomic burden. And the estimated cost within the UK is currently about £50 billion per year. And again, with the increasing prevalence of dementia due to an aging population, we are expecting that socioeconomic cost is going to increase. And globally, it's sitting currently at about $1 trillion per year in 2018, and it's forecasted to be $2 trillion per year by 2030. So clearly, there's a need for us to study this also from an economic point of view. And to put that into perspective, because I think when you hear numbers of this scale, sometimes it's almost meaningless, isn't it? Like, it's very difficult to know how much is $1 trillion. But actually, the socioeconomic burden of dementia is greater than that of cancer, stroke, and chronic heart disease combined. And the funding that dementia research receives is comparatively low, compared to cancer and chronic heart disease, relative to the economic cost or impact of the disease. Dementia is fairly poorly funded. Now, I would say that this data was from 2015, article published in 2015. I suspect that there's been a slight shift recently, and I do think that funding has improved in the sort of dementia research landscape, but still we've been lagging behind for several years. So let's talk a little bit about Alzheimer's disease, which is the most common cause of dementia. Hopefully by now I at least convinced you a little bit that dementia is important and worth studying. So Alzheimer's disease, the main sort of finding is extensive loss of brain tissue, and you could see this just by visually looking at the brain of somebody who's died with advanced Alzheimer's disease or on MRI imaging. But there's a few neuropathological hallmarks. So the main one is protein aggregation. So in the brains of people that have died with Alzheimer's disease, there's extensive extracellular accumulation of a protein called amyloid beta, which forms these plaques, and the accumulation of a protein called tau within cells that forms neurofibrillary tangles.
Tau.
And this causes a lot of inflammation. So we see that the immune cells in the brain, the microglia and the astrocytes, become very reactive. And there's changes to the blood vessels as well. That amyloid beta isn't just accumulating extracellularly within the interstitium, it also accumulates within the walls of the blood vessels, and that's that green staining there, lining the vasculature. And this causes problems with blood flow to parts of the brain. And there's also extensive synapse loss. Now, something that's important about Alzheimer's disease is the kind of cascade of events that happens, and the duration of which it takes for these things to occur. So Alzheimer's disease has a very prolonged preclinical phase. We think that the pathology starts in the brain almost 15 to 20 years before the onset of symptoms. And it starts first with this amyloid beta deposition. And then, this is a little bit debated, but one of the most common sort of theories is the amyloid cascade hypothesis, which is that amyloid beta deposition starts first. This sets off a severe sort of neuroinflammatory response. Those microglia and astrocytes, the brain immune cells, become reactive. Then later we get the tau pathology forming. And then this causes our loss of our brain cells, our neurons, and the connections between the brain cells, the synapses. But you can see on this graph, by the time, this dotted line in the middle, by the time that somebody has the clinical signs of Alzheimer's disease, by the time someone has dementia, the amount of pathology in the brain is really extensive. And actually, it's important to think, when we think about interventions, actually, if we can intervene in the preclinical stage, and we're much more likely to have a successful clinical outcome. So I'm a little bit biased. There's a lot of my focus is around synapses, which you'll come on to see. But of all the things that we can measure in the brain, synapse loss has the strongest correlation with the clinical signs. It's the strongest predictor of cognitive decline. And this was first shown by Tukosky and Sheff in 1990. And this has been a very robust and reproducible finding that's been shown time and time again using different methods and different cohorts, that of all the things that we can measure, it's the synapse loss, which is the most important thing for predicting cognitive decline. And any sort of, neuroscientists, neurobiologists out there, it's not going to be a surprise to us, right? The synapses are the connections between our brain cells, our neurons, and if they can't communicate properly via the synapses, then that's going to cause a functional problem, and we're going to see some clinical signs associated with that. So let's think about research into neurodegenerative disorders in general. But really, I think this quote is quite, I like this quote, but again, I'm biased, and that's that the best material model for a cat is another, or preferably the same cat. And I think that this is probably true for most research, but I think that it's particularly true when we're thinking about research into neurodegenerative diseases. And there's evidence to really support that. And one reason is, despite decades of research and billions of dollars spent on this research, the translation from treatments that are successful in a research setting to passing clinical trials is very poor. And over 99% of Alzheimer's disease treatments have failed in clinical trials. We've got very, very good at giving mice Alzheimer's like disease and then curing it, but when we take those treatments to clinical trials, they fail over and over again. And one of the main reasons that this has been one of the main reasons proposed for this failure is that our model is not very good. It's not very good at recapitulating the human disease, and for lots of reasons. One is that there's just differences in a mouse brain and a human brain. One of interesting, quite key difference is actually mice have what we call like a smooth brain, so a less encephalic brain, whereas humans, the same as dogs and cats, have the sulci and gyri in the brain that's quite folded. And there's just distinct different physiological characteristics between the way in which the neurons and cells in the human brain are different to that in a mouse brain. The other reason is that laboratory animals, our rodent models, do not naturally develop the pathology, this amyloid beta and this tau in their brains, in the same way as humans. We have to induce it somehow through things like genetic mutations and viral transfection, and clearly this isn't the same. And what a key point was that I showed you on the previous graph is that this pathology is building up slowly over a couple of decades, and it's a disease of aging. Aging is the biggest risk factor for Alzheimer's disease, and actually we just can't recapitulate that in a mouse model where we're rapidly inducing a phenotype within a couple of months. So the take home is that Alzheimer's disease mouse models are just not fully representative of the human disease. So is there a better, more translatable way to study dementia-causing disorders? And I'm going to talk to you about two kind of key things. One is studying human brain, and we're gonna start there, because if we go back to my quote, which is that the best material model for a cat is another or preferably the same cat, actually we need to learn everything we can from the human brain. Now we can do that via looking in post-mortem brain, and I'll show you some data from post-mortem data shortly. But also I want to talk to you about a technique that we've been optimizing over the last few years, and this is living human brain slice cultures. Now this is where patients who are undergoing surgery for brain tumors, to access that brain tumor, the surgeon has to remove overlying sort of normal cortical tissue. Now, previously that tissue was just being discarded, but with informed consent from the patients, we take that tissue, we slice it, we put it in a dish, and we culture it, and we keep it alive. And this has really been a collaborative approach. Dr. Claire Durrant, alongside Professor Paul Brennan, neurosurgeon, have been, pioneering this. And the data that I'm about to show you has been a team effort between myself, Claire, and Soraya, who was a postdoc in Claire's lab, and she's just got herself a Race Against Dementia fellowship. So we've discussed this briefly, that we collect this tissue, we're going into the surgeries, and as the neurosurgeon's removing this piece of tissue, we're taking it, we're putting it immediately on ice to preserve it, we slice it, we culture it, and we're keeping it alive in these little dishes. And we're having regular meetings to work out how we can improve this process, because it's a logistical challenge for a number of reasons. So the first thing we wanted to do is, determine whether or not we're keeping them alive. And there was a period of time where I think we were just keeping dead bits of brain tissue in a culture disc in the incubator, because it's not an easy task, and it took a lot of optimization. But now we're quite confident that we can keep this human brain tissue alive in culture, and this is just showing that there is the normal brain architecture. We have neurons, astrocytes, microglia, which are all alive, and actually neurons, the cells in the brain, when they fire, they have electrical activity, and we can still measure that electrical activity in these human brain slices. Just another level of evidence to say that they are sort of living pieces of tissue. So then, with a focus on amyloid beta pathology, which, amyloid beta is one of those key proteins that builds up in the brain in Alzheimer's disease. We wanted to see if we could manipulate amyloid beta levels in these human brain size cultures, and to do that we've used three experimental conditions. One which is where they have control or medium only, one where we expose them to a drug called phosphoramidin, and one where we expose them to a BACE inhibitor. And what we see is that this is our control. So from baseline, we are consistently increasing the levels of amyloid beta with our phosphoramidin, and we're decreasing the levels of amyloid beta with our BACE inhibitor. So we can keep these human slices alive, and we're able to manipulate the production of amyloid beta. So then what we're doing here is we're looking at the synapses. Remember those really important connections between brain cells. And we're looking at synaptophysin, which is shown in cyan, which is a presynaptic protein, and PSD95, which is a postsynaptic protein. And interestingly, this graph on the right shows us that, interestingly, manipulating amyloid beta levels in either direction, so if we're decreasing it or increasing it, we're seeing synapse loss. Now, this was a little bit surprising. What we were expecting to see was that, amyloid beta was bad. So if we increased it, it was bad. But actually, if we decreased it, we thought maybe that would be good. But actually, what we're looking at here is relatively normal, healthy tissue. So, what we think is happening is that amyloid beta in physiological levels is actually important for synaptic function. And if you remove that amyloid beta, we see synaptic pathology. But equally, if that amyloid beta becomes toxic, if it aggregates and forms these clumps and these plaques, then it also becomes toxic. So too low is bad, too high is bad, and there's this sort of physiological sweet spot, which there is other evidence from within the field looking and supporting this, and actually amyloid beta has got a role in multiple physiological functions. Is probably there for a reason. So then the second thing we wanted to do was, okay, well, let's just look at like bad amyloid beta. So we've taken the brains of people who have died with Alzheimer's disease, we've smushed them up, and we've extracted the amyloid beta from those brains, and we've applied it to living human brain slice cultures. And then again, we've done some high resolution imaging where we can look at individual synapses. And what we found is that the human brain slices that were exposed to the amyloid beta from Alzheimer's disease brain, it's that amyloid beta starts to stick together and aggregate, which is what this first graph is showing. That amyloid beta starts to stick to and bind to synapses, and this results in synaptic loss. So this is a very sort of key pathological feature of Alzheimer's disease that we're recapitulating in our human model in living human brain tissue. Now, the other thing that we thought was, well, actually, these people don't have dementia. As far as we're aware, they're having brain surgery to remove tumors, but there's a wide range of ages of these patients, and perhaps some of these patients are already starting to develop Alzheimer's-like pathology. Maybe they're in that preclinical phase. So what we did is we just stained their brain for amyloid beta, and what you see here is an example of an individual that has an amyloid beta plaque in the brain. And here is these tau tangles, this hyperphosphorylated tau. And so actually, even just taking this living human brain, already they have some of this pathology just naturally that we can study. So take-home points from our living human brain slice cultures is that we can pharmacologically alter the levels of amyloid beta in this brain tissue, and we can spontaneously find amyloid beta and tau pathology, so Alzheimer's disease-like pathology in these living human brain slice cultures. And this provides a really unique opportunity for future experiments where we don't need to use mice. And actually, there's a lot of arguments to say that this is going to be better, more translatable. We don't know that yet. It's still early stages, but it's currently a logical conclusion that's supported by a lot of research in the field. So I'll probably I might end up going over this bit a little bit quickly, just thinking about time. I'm just going to skip over it, and I'm going to skip to the cat stuff because I think we'll be a bit short on time. Apologies if anyone came to hear me talk about this paper. So one way is using our living human brain slice cultures. So we're looking at human tissue. But the other thing is, well, find these laboratory models aren't very good where we're inducing the disease, but are there naturally occurring models of the human disease? Do other animals develop Alzheimer's disease-like pathology? And yes, they do. This is a great review published in Brain Communications last year, and actually what you can see along the top is for humans, we have our amyloid beta plaques, we have our neurofibrillary tangles, brain atrophy, neuronal loss, pigment accumulation, and our cerebral amyloid angiopathy. And in a wide range of animals, it's been shown that as they age, they also develop some of these pathologies. So dogs develop quite extensive amyloid beta plaques, extracellular dense core plaques. They do hyperphosphorylate tau, but they don't get tau pathology quite in the same way as people. And in cats, we see amyloid beta plaques. There's a very slight difference. Their amino acid sequence of amyloid beta is one amino acid different. And we just see generally a slightly more diffuse amyloid beta plaque rather than these dense core plaques that we see in human Alzheimer's disease, but very comparable. And actually, we do see more tau pathology similar to what we see in humans. So fine, they develop the pathology, but do they develop dementia? Well, in some cases, we know yes. In other cases, we don't know. But what we know is that dogs and cats both develop a condition that we call cognitive dysfunction syndrome. And that's very comparable to dementia in humans, where what we're talking about is a clinical syndrome. It's a set of clinical signs. And in dogs, we use this acronym DISHA, which we can break down to show that they have signs of disorientation. So sometimes we can see things like them getting stuck in corners, some head pressing type behaviors. They become disorientated in new situations, like if they're taking out the house or if people move furniture within the house. We can see changes in interactions, and that's between both dogs and their owners, and also between dogs and other dogs. Disruption to the sleep-wake cycle, and this is a big one in human Alzheimer's disease, but where they're sort of up during the night. And then behavioral changes such as like house soiling, loss of previously learned behaviors, and then activity changes and anxiety. And in cats, we see a comparable condition, but we use Vishtal, which was sort of pioneered by Professor Planiogam here, just to really capture one of the key differences between feline and canine dementia. And this is the focalization, and the vocalization that cats have often at night can become profound. It's one of the the reasons that often they're brought to us on clinics, is because that's quite disruptive to use. You can imagine the human animal bond, and that their cat suddenly up all night meowing, seeming distressed. So what about prevalence? Is this common or is this rare? And I think the true prevalence we don't know, but there was a questionnaire-based study that showed that the proportion of pets showing at least one clinical sign of cognitive dysfunction syndrome is actually very high. So we're seeing 28% of cats between the ages of 11 to 14, and about 50% of cats aged over 15 years. And in dogs, it's similar, but actually dogs over the age of 15 years, we're seeing nearly 2/3, 68%, and just over 2/3 of dogs are showing signs of cognitive dysfunction syndrome or dementia. So we have this naturally occurring model of dementia. These cats and dogs are developing these symptoms, and they're developing the pathology. So this is one reason why we think that they could, of course, be worth studying for two key reasons, of course: to help them, to help our cats, to help our dogs, but also are there insights that we can gain from studying dementia in cats and dogs, which can provide a sort of bi-directional translational benefit to humans as well. So one other key reason that we think cats and dogs might make better models than mice is because pets share their environment and lifestyle with their humans. And actually I find this study fascinating, and it's that dogs with diabetic owners were 48% more likely to develop diabetes than dogs with non-diabetic owners. And that people who owned a pet that went on to develop type 2 diabetes were then associated with a 38% increased risk of developing diabetes themselves over a 2-year period. And the thought there is that dogs are a little bit like the canary in the canary in the coal mine for shared diabetogenic risk factors, because things like a sedentary lifestyle, diet, exercise, secondhand smoke are shared between pets and humans. Now, why is that important? Why am I bringing that up here? Well, actually, the Lancet Commission published in 2024 that actually 45% of dementia cases can be prevented with modifiable risk factors. And that's some of these things that we've just spoken about. So being overweight, obesity, type 2 diabetes, high blood pressure, smoking. The animals aren't smoking, but secondhand smoke in the home that we know that these pets are exposed to, and physical inactivity. Now, of course, some of these aren't are going to be shared, such as educational, less education, but actually, you know, we think that this is another reason of the shared lifestyle. Dogs, cats, living together with humans, these shared environmental risk factors that are really important. So we're just going to focus a little bit on cats, and what I already spoke to you about is that we know cats develop amyloid beta pathology. So this was the top row here. So this is amyloid beta staining in the parietal cortex of a cat, and they also develop this hyperphosphorylated intracellular accumulation of tau. But the relationship between amyloid beta pathology and cognitive dysfunction in cats hasn't been fully established. So we know as cats age, they develop this amyloid beta pathology, and we certainly see a lot of amyloid beta pathology in the brains of cats with cognitive dysfunction syndrome. However, and this is actually similar to in humans, the amount of amyloid pathology doesn't correlate with the degree of cognitive dysfunction, and that had been shown in cats. So there's a little bit of a question mark as to is this an age-associated change, or is that amyloid beta pathology exerting a toxic or pathogenic effect within the feline brain? And that's one of the questions that we set out to answer. And we were focusing on two key things, really revolving a little bit around synapses, because we know in human Alzheimer's disease, it's the loss of synapses that correlates closely with the progression of disease symptoms. So if we can work out the mechanisms by which we're seeing synapse loss and preventing that, and then this is clearly a promising therapeutic strategy. So specifically, a little bit related to the work I've just shown you in the living human brain size cultures, we want to know, does amyloid beta directly accumulate within the synapses in the feline brain, the same as the human brain, where it might be exerting a pathogenic effect? And is that amyloid beta causing neuroinflammation, so that activation of immune cells, the astrocytes and the microglia, and is that causing increased engulfment of synapses by glia? And I've not really introduced this concept to you, but something that we know that happens in human Alzheimer's disease is that when we see this neuroinflammation, those microglia and astrocytes become overactive, and actually they start sort of eating up and removing the synapses from the brain, and this removal of synapses is likely contributing to the progression of disease symptoms. So what we did is we took the brains of cats that were young, that were aged, but reported to be cognitively normal, and aged and had cognitive dysfunction syndrome. And we've stained for amyloid beta, which is this magenta staining here, and also for synaptic marker, which is shown in cyan. And then this graph here is showing us the percentage of synapses co-localizing with amyloid beta. And what we were finding, and what you can see from these 3D reconstructions, is that amyloid beta is directly accumulating within the synapses in the feline brain, where it's likely exerting a pathogenic effect. Now, then when we looked at the effect of amyloid beta on our immune cells, first I'm going to show you what happens to microglia. So what we're looking at here is within the same brain, we're looking at an area next to an amyloid beta plaque. So just adjacent, one field of view over from where there's an amyloid beta plaque, and then we're looking directly where there's an amyloid beta plaque. And we're looking at the amount of microglia staining, so our IBA1 staining, and then the amount of co-localization between our microglia and our synapses. And what we see is this graph here is the amount of microglial staining that we're seeing. And we're seeing that when we're looking around the plaque, there's more microglial staining, suggesting that that amyloid beta pathology is causing a microgliosis. So they're becoming reactive and causing neuroinflammation. And then we look at the co-localization between our microglia and our synaptic marker. And actually, we're seeing more synapses inside the microglia around the amyloid beta plaque. And we're seeing that microglia are eating up those synapses that contain amyloid beta, which I showed you on the previous slide. And what's interesting is in this graph on the bottom right, what we're showing is that when we look at the synapses with amyloid beta, which are these two here on the right-hand side of the graph, synapses containing amyloid beta are much more likely to be engulfed by microglia than synapses that aren't. So this is supporting that we're seeing this amyloid beta accumulating within the synapse, and then this is causing a cascade of events that leads to microglia coming along and removing those synapses. And then we sort of found pretty much exactly the same thing for astrocytes, another immune cell in the brain. So that's the staining here in grey, where our first graph here, we show that around our amyloid beta plaques, we're seeing astrogliosis. So those astrocytes are also becoming activated and are also gobbling up the synapses that we see in graph C and D. Now, interestingly, and this is quite interesting when we're taking this back to what we know in humans, is there's been a little bit of a debate as to how responsible is amyloid beta for this microgliosis and this increased synaptic engulfment. And actually, what we think is that when it comes down to microglia, the amyloid beta is very important. And what we found was that those synapses containing amyloid beta were much more likely to be engulfed by microglia. But actually, that's not true for astrocytes. And actually, there's possibly a different pathway that's responsible for this astrocyte-mediated synaptic engulfment. And this is a really good example where I appreciate this is very niche to the field, but where the insight that we've gained from this study does have a bidirectional translational benefit and is actually providing some insight into what might be happening in the human disease. So then we thought, okay, fine. So we know that amyloid beta is having a toxic effect in the feline brain, but actually what we want to see was, is there a difference between our aged cats without cognitive dysfunction and our cats with cognitive dysfunction? And what we found is here we're doing correlations between the amount of amyloid beta and all of those pathological readouts that I've just spoken to you about. And what we found was that in the aged cats, although they have the amyloid beta, and remember I mentioned this to you earlier, that we don't always see a correlation between amyloid beta and our clinical signs. And in the aged cats, we're not seeing an association or a correlation between the amount of amyloid beta and our neuroinflammation and our synaptic engulfment. But we are seeing that in our cognitive dysfunction syndrome cats. And what this suggests that maybe it's not just about the amyloid beta, but it's about how the brain is responding to that amyloid beta. How much neuroinflammation is it causing, and how much glia-mediated synaptic engulfment is happening, and maybe these are the things that are really contributing to the clinical signs, not just the amyloid beta. So what's the future of cognitive dysfunction research in cats and dogs? Focus a little bit on cats here, but there's a lot of research that's been done in dogs, some in like research dogs, research beagles in the US, but we're learning more and more in our pet dogs as well. So one of the main things is in humans, part of the diagnosis is really important that we get good cognitive testing, and actually this isn't something that we have in the veterinary world. We rely heavily on questionnaire-based measures. So owners fill out a questionnaire and we give a point system of cognitive dysfunction based on owners reporting, which is good. It's super useful. But owner-based questionnaires obviously have limitations. And actually, if we can combine our questionnaires with some objective cognitive testing, like it's being done in humans, and this will really improve our diagnostic certainty. And actually, Professor Danielle Gilmore and Amy Meal are working at a study at the University of Edinburgh, looking at just this, trying to get a good cognitive test for cats. So the other thing is, in the last decade, there's been huge progress has been made in diagnostic and predictive fluid biomarkers in the Alzheimer's research field. We now have a fluid biomarker, which is the plasma levels of p-tau217, which can predict people who are going to develop Alzheimer's disease 10 to 15 years before they start showing symptoms. So we're picking them up in that preclinical phase that I showed you earlier on that chart. And actually, this is a very good way of diagnosing Alzheimer's disease from other types of dementia, and also allows us to identify patients when they're in early stages of the disease and therapeutic intervention might be more important. And actually, that's one of the things that we're just really missing in cats and dogs, is a good diagnostic biomarker to improve our diagnostic certainty. So one of the things that we're looking at doing is developing and optimizing a biomarker for amyloid pathology in the cat brain. And the other thing is, we don't really have like a gold standard of diagnoses at all. So gold standard in human Alzheimer's disease field is post-mortem, but we don't have neuropathological diagnostic criteria for this disease in cats and dogs. And something which is a really important point, which I haven't gone into in too much detail, but is that cognitive dysfunction syndrome is comparable to dementia in that it's a clinical syndrome. It's not actually a disease. And really, we're trying to study it and think about it and trying to find what is the disease causing cognitive dysfunction syndrome in cats. But the reality is it's probably more than one disease, the same in humans, that maybe we do see amyloid-associated cognitive dysfunction syndrome in cats, but maybe there's also a vascular form of dementia or a Lewy body form of dementia. And at the moment, we're grouping all of these cats together in our studies, whereas actually really trying to find out if there's multiple diseases that can be causing cognitive dysfunction syndrome will be really important moving forward, and developing some neuropathological diagnostic criteria to make sure that we're diagnosing and categorizing these cases appropriately. So just, I realize I've gone over a tiny bit, but I am almost done. So I want to end on a high, and that is that it's a really exciting time in Alzheimer's disease research at the moment. And that's because within the last couple of years, there's been a couple of drugs that have been approved for treating Alzheimer's disease. And what they are is they're monoclonal antibodies against amyloid beta. So they get into the brain and they remove amyloid beta. And this graph here is showing you the amount of amyloid beta in patients receiving the placebo and the amount of amyloid beta in patients receiving the treatment. And what we see is this is cognitive decline, and that's that patients who are receiving the antibody that removes amyloid beta show a slower rate of cognitive decline than placebos. Now, clearly, these people are still getting Alzheimer's disease and they're still getting worse. The signs are still progressing. It's just not progressing as quickly. So clearly, there's a lot to learn. But it's promising and it's a step in the right direction. And part of the rationale for the study looking in cats was great. Now we have these treatments in humans removing amyloid beta. What's the rationale? Can we take advantage of that in veterinary neurology? Is there evidence to say that cats and dogs would benefit from these therapies? And one of the things we wanted to show that actually amyloid beta is having a toxic or pathological effect within the feline brain. And the interesting thing was, we weren't that bothered about the outcome of this study, because if it wasn't, that would be very interesting. But the fact that it is very interesting as well. And I think we're a little way off of it. but hopefully in my lifetime we'll start to see some of these advances in the human Alzheimer's disease field trickle into veterinary dementia research. So I'll end on this, leave this slide here, which is just just to say that Amy and Danielle are actively recruiting cats for ongoing research into this feline cognitive dysfunction, looking at optimizing that cognitive test that we were talking about earlier. And actually what we're doing is we are collecting blood from these cases, and you know, our hope is then we have a sample, a biobank of blood samples of cats that we have known cognitive testing, and then this is going to be a really valuable resource for developing those diagnostic biomarkers that I spoke to you about. So if you're in, you know, the Edinburgh area, the Scotland area, either you have a cat or you're a vet, you know, just referring these cases would be much appreciated. So huge thank you to absolutely everyone. Clearly this work wouldn't be possible without the donors, the patient donors, the families of the donors, and the people who have kindly donated their pet cats to this research. So a huge thank you to them. Huge thank you to the Wellcome Trust who funded me to do a lot of this research, and also it really does take a village. I've had a huge amount of support. I've worked in some hugely incredible teams, and I just want to say thank you to all the people who have supported me along the way. And then finally, if this was of interest to you, we are arranging a conference, and the focus is an update on human and animal neurodegenerative disorders. It's going to be taking place in Edinburgh at the Royal College of Physicians on the 2nd of October. And a huge thanks to, you know, the Humanimal Trust and Brain Health Arc, who are providing funding to support this meeting. And I'll just leave it there. Thank you very much. Sorry for running a little bit over, but hopefully we still have some time for some questions.
Not at all. Thank you so much. That was incredibly interesting. I mean, some, I have to admit, not being a scientist, went a little bit over my head, but I found it hugely interesting. I liked the bit about the diabetes as well. I think there's so many comparisons there. I mean, obviously here at Humanimal Trust, we advocate for clinical trials on real patients rather than inducing disease into an otherwise healthy animal model. And obviously we'd also hope that one day, you know, that those clinical trials would make animal testing obsolete. Something just struck me at the end, and apologies if this wasn't right, or I didn't understand it. You said about this exciting time at the minute with these drugs being developed to help human patients. Did I get it right? Are these drugs also then being trialed, clinical trials on real cat patients at the moment, or is that the next step?
Yeah, not currently, but this is a key area that, you know, we're sort of trying to work towards getting to that point. I think we probably need to improve our diagnostic criteria a little bit and trying to identify the patients who would benefit from these treatments as early as possible. And that's why things like these diagnostic fluid biomarkers, but it's certainly something that in my sort of, I don't know, 5-10 year plan is to start doing some clinical trials in cats and dogs, and hopefully, as we say, can benefit from these advances in human neurology.
Yeah, thank you so much, Robert. Right, we'll open the floor to questions then, please. Any questions in the chat? No, just all saying fantastic talk, super interesting. Thank you, Rob. Excellent work. Our very own Alex Deadman has a question.
Hi, Rob. Thank you. That was such an interesting talk. I love I never thought that the same way that we think about diabetes and the way that the environment affects both, I didn't apply that to dementia before this talk. I was like, of course, that makes loads of sense. So it's brilliant. I just had a question. It sort of leads on a bit from what Joe was talking about there and you said we need to improve the diagnostic criteria of cognitive decline in, say, cats. What do we know about that? Because I know I was really interested that we can now tell so much really far in advance that dementia is starting to happen, or signs of it that it could be happening for humans. Where are we at for the cat patients in that field of being able to spot it?
Yeah, so unfortunately only really when they're starting to show clinical signs, and usually by the time that we see these patients, they are quite far along in the disease process. And I suppose one of the reasons that we think that some of the clinical trials, the earlier clinical trials, failed was because these drugs were being used in patients that already had quite advanced Alzheimer's disease, and that by this point is probably a little bit too late, and that a lot of the damage has been done. So yes, in the human field, we can predict the people who are going to develop Alzheimer's disease much better. Currently in veterinary neurology for cats and dogs, we don't have a good way of doing this, but this is my the main thing at the moment that I'm really wanting to focus on is the development of comparable biomarkers, so that we can identify these patients who are at risk. And actually the way that it would work on a population level, or like a veterinary population level, would be that it would be integrated into a senior pet health check, where animals are going for the vaccinations at a certain age. There's value in doing like a urine analysis and taking some bloods, check a wide range of health parameters like thyroid function, liver function, kidney function, and actually integrating into that a biomarker for patients at risk of neurodegenerative disease, so then we can identify the ones that are at risk early. And this is certainly where the field's going in human Alzheimer's disease research, and this is really the key step for me, because then from starting those clinical trials, this is going to be very important. And fortunately, throughout my PhD and presenting this research at various conferences, I've come into contact with some very amazing people, and Henrik Zetterberg, who's really pioneered a lot of this biomarker work, has recently agreed to collaborate with us and help us really develop these biomarkers. So it's early stages, but we're setting up that collaboration, and we'll be looking for things like funding moving forward to help support that research.
Thank you.
Brilliant. Thank you, Alex, and thank you, Robert, for answering that. Just seeing if there's any more questions. So any more questions before we wrap up and let everyone go off and hopefully enjoy their bank holiday weekend? No, I can't see anyone. Thank you, Robert. Really enjoyed that, learnt so much. Really appreciate your time today when you are so incredibly busy, and also really appreciate what you're trying to do. Having had a dog with dementia for the last year of her life, bless her, and now having one of my cats who I know has got stages of dementia, and learning to care for her the best I can. It's really, really interesting, and I truly hope one day, certainly in my lifetime as well, that there will be something more we can do for humans and animals that are suffering from dementia. So thank you again, and thank you all to the people who've joined us today, coming away from your busy schedules on a Friday afternoon. Thank you very much indeed. We truly appreciate it. If you want to learn more about Human Animal Trust, please have a look on our website and see what we're trying to do, and the other webinars that we've hosted as well. Thank you very much again, Robert, and to all the attendees. Thank you, and have a lovely weekend.